Welcome to Work Comp Talk, the workers' compensation podcast. I'm your host, Bilal Kassem, and not joined by me today is Carmen Ramirez. She's here, but not here. She's behind the camera. We do have our wonderful guests here today, Dr. Jamasbi, Donny and Dr. Morley, who are going to be explaining everything there is to know about primary treating physicians, nurse case managers, and physician's assistants in the workers' compensation system. And if you like what you hear today, make sure you hit that like and subscribe button, and make sure you check out our other podcast episodes. So without further ado, let's jump right in. Dr. Jamasbi, tell us a little bit about yourself, your background, your education, and what you do.
I actually have an engineering background, undergrad, and went to medical school after that. So I had a good perspective of work environment before entering medical school. After medical school, I did a year of general surgery internship, did my anesthesia residency at University of California, Irvine, and then came up to Stanford and did a interventional spine and pain management fellowship. My practice started out as primarily treating cancer patients, chronic pain of cancer patients, and then gradually the referrals that came our way ended up being non-cancer patients and workers' comp patients, and our practice developed in that direction, and now we have a very large workers' comp practice in Northern California.
Awesome. Donny?
Yeah, my background actually started in the tech field. And I was working for Johnson & Johnson for a bit, and then decided to do a career change and went to PA school. Graduated with a master's in physician assistant studies and public health. Joined PRC, and I've been here ever since. I've been here for about 12 years.
Dr. Morley, how about you?
I'm a lifelong Californian. I kind of always wanted to be a doctor. And then when I was in college, I became involved in doing hospice work. A family member of mine ended up passing away from cancer. And then I knew kind of wanted to go into pain medicine when I finished medical school residency. And then similar to what Dr. Jamasbi said, our practice really focused on cancer pain management. We started being sent a lot of injured workers who had a variety of problems causing chronic pain, and became very focused. Probably 70-80% of our practice now is treating injured workers.
And for any of you, tell us a little bit about what pain and rehab consultants is. What's the philosophy for your business and your medical practice?
We concentrate on really rehabilitating patients from their chronic illness or their chronic pain. We use modalities to relieve pain, but really our focus is to making people more functional. And we use interventional techniques, we use medications, and we use rehab modalities to bring patients to a higher functional level. Because at the end of the day, if you cannot get rid of the pain, you still got to make the patient more functional. So that's really the focus of our practice.
Dr. Morley, do you have anything to add?
I'd say that, and probably we'll get into a little bit later, Bilal, but we're typically, when we're sent injured workers, are the primary treating physician. And I think, I might be treating someone with an orthopedic injury who's got a knee problem, but they've also got a head injury. But I think that part of that comprehensive care we really assume here, we're going to be the captain of the ship. So if patients come to us and they need help getting their head injury worked up, they need the neuropsychological testing, they need cognitive rehabilitation, they need MRI imaging in the head. Even though that's not our primary specialty, we really do provide comprehensive care. We're going to take on the responsibility for that entire injury and making sure that patients are sent to us, get the entire workup and treatment they need, no matter what specialty it's in.
So we have a lot of listeners who go through workers' comp and it's their very first time. So, acronyms like PTPs and RFAs, UR, and all that stuff, it's like a foreign language to them. So in your particular context, what is a primary treating physician?
I think for me, it's in workers' comp, it's the designation of the physician who's responsible for essentially determining your work status and deciding when your injury's at what's called maximal medical improvement, when it's kind of all done and you're going to receive your rating. But in between that, you really do kind of need a captain of the ship. And I think that some physicians are willing to take this on more than others, Bilal, as you've seen. But you have to make sure that essentially that injured worker is getting all the workup and treatment that they deserve and need in the workers' compensation system. And that's as you well know, increasingly complex and difficult sometimes. It's not always easy to get all the treatment that injured workers need. But I think you need someone in your corner who's going to take on the responsibility of making sure that you can become as well as you can be. And that requires really interfacing with the workers' compensation system as the physician, being an advocate for an injured worker, and helping them get as healthy as they can be following that injury.
Dr. Jamasbi, you have anything to add?
Well, I think Dr. Morley put it really well. The primary treating physician is responsible for getting all the treatment authorized. So it's really important to have a primary treating physician that understands not only the medical illness, but also the system. How does the system work? How do I get the treatment authorized? Because as you know, getting treatment authorized is very challenging in the workers' compensation system. And the primary treating physician should have a practice where they have the appropriate ancillary services that allows the patient to get the treatment authorized in a timely fashion. So that's really important. The clinical part obviously is extremely important, but understanding where the patients stand in terms of management of their cases. They only have a limited time for total temporary disability. There's a timeline for other things, and the primary treating physician needs to understand those timelines and those requirements so that the patient's case moves along as well as being able to get the appropriate treatment.
So, one of the biggest issues we see, at least in the law practice, is that there seems to be a misunderstanding about what treatment the doctors can provide, in particular the difference between, for example, seeing your primary care physician who may send a prescription down to a pharmacy and you get it same day versus primary treating physicians who actually have to request authorization for treatment. And so we have utilization review in workers' comp. Can you explain, what that is?
So I'm just going to give you a little historic perspective. When I started practicing, there was an assumption of correctness for treating physician, which means that the treating physician recommended something. There was a 99% chance that the patient will get that approved within a day or two. That went away, and the insurance companies provided extra barriers to limit treatment so that there's cost savings. And those limits have become more stringent over time. First, we had utilization review, which could be challenged. Then they made it more stringent. Then they developed IMR, which is independent medical review. But it's basically allowing the insurance company to monitor and possibly deny some of the treatment. The utilization review system is not a perfect system. The doctor that reviews the treatment request is usually not someone that is familiar with the patient. They've never examined the patient or interviewed the patient. They have access to a limited amount of medical information. So the decisions are not the best sometimes, but that's a system we have to work with. So as primary treating physicians, we have to become experts of how to interact with utilization review to maximize the possibility of getting treatment authorized.
So would you say that utilization review has impacted your practice in patient care for the better or for worse?
Well, I think that it has made getting treatment authorized a lot more difficult. And we obviously do not agree with the denials, because when we recommend the treatment, we have already considered all the possibilities and we have picked the best treatment for that patient. And when we request something, we are certain that that's what the patient needs. And when the utilization review denies that treatment, it makes things more difficult for us and for the patient.
So piggybacking on that, Dr. Morley, how do you set expectations regarding treatment process with your clients?
Well, most of the patients we've seen they've had some experience with the workers' compensation system already. Generally, they were sent to an occupational medicine clinic, and they've been in the system for a couple months, and things haven't happened very fast. And most patients that I see come pre-frustrated, I would say, with not really having their expectations met for quality medical treatment. And I think that I have to be realistic with them and say that the treatment I request is not going to be authorized as quickly as their experience has been, like you said, seeing their regular doctor. When their regular doctor wanted a blood test or an X-ray or an MRI, they are probably getting it done that week, and that's not going to happen in workers' compensation. But I do explain to them, this is how I'm going to submit the request. We're probably not going to hear anything back for a couple weeks. If they deny it or want for more information, we're going to fight for that. And Some things I can feel relatively certain that I'm going to get this authorized for you. It may take 3 or 4 weeks, but it's going to happen. Other things that are more difficult, I tell them, hey, I can't guarantee this. It may be a longer fight. Just so the patients understand, the way the system is set up is there is a guideline, what's called the medical treatment utilization schedule, and it's supposed to say for this body part, for this type of injury, for this medical illness, this is the treatment that an injured worker should have access to. But the system that Dr. Jamasbi described that's been set up now, it's complicated enough that if a reviewing physician wants to say no, they can. I might say, hey, they need an MRI examination of the shoulder, and the guidelines might support that. But a reviewer could come back and say, well, I don't think Dr. Morley's physical exam really documented well enough that they had limitation of the shoulder. Or it's not clear to me that this injury to the shoulder is really providing enough functional limitation. So that can be very frustrating for injured workers. And I think one of the things that we deal with a lot, and Donny in the trenches seeing follow-up patients so frequently can speak to, I think, is that if you're someone who had a work-related injury and that you were doing your best for your employer, really trying to provide them a good day's labor, help the business that you're employed at, and then for no fault of your own, you have an injury and you're not getting the treatment that you feel you need, and maybe even these unknown physicians reviewing your case, questioning, like, do you need something? Are you motivated to get better? Were you really injured? It's really a setup that I think would make me feel resentful, and I think a lot of the patients I deal with, and it can be really damaging. And I think what all of us try to do here is we want people to be as healthy as possible and get them on as thinking as positive they can. Let them know that we're in their corner trying to help them. We will try to get them to the finish line because it is pretty frustrating.
And I agree with Dr. Morley. I think, as we all know, workers' comp can be a grind, especially with all the denials, utilization review, IMRs, QMEs. And so what I usually tell patients is, you have to have patience in workers' comp, right? It's going to take a long time sometimes for authorizations to come in and for the treatment plan to come together. But I also say that, hey, we have to be proactive as well, right? You can't just wait for workers' comp to just always authorize things. So, for example, I had a patient that was authorized for physical therapy, had 6 sessions, was starting to have some benefit, and then they denied more. And so what I tell them is, hey, you got to keep up with your exercises, the things that they taught you, the stretches, so that if more physical therapy is authorized later on, they can take you from here to the next level instead of starting all the way down at baseline.
Do you guys have any idea anecdotally what percentage of requested treatment is denied versus authorized?
We know for our practice precisely. So if the process to get treatment authorized is a formal request, that's called a request for authorization. You're supposed to get an answer for that in 5 days. So an initial yes on a treatment request for us is about 40 to 50%. And it varies a little bit on the treatment, whether it's medications or some other type of treatment. After that process, if they deny it, you can appeal the utilization review decision. That's called utilization review appeal. And then if that's also denied, you can go to something called independent medical review, or IMR, which you've heard us mention. IMR is very similar to utilization review, where you have a physician you don't meet, they don't talk to you, they just look at the records and decide whether you get the treatment. After that's all done, we get about another half of the 50% denied. So we get to about 70 or 75%. And
surprisingly a lot.
Yeah, that's about, but that to get to that 75%, that might take 2 months, and that's where the rub comes in. That's pretty rough for patients.
And one of the things I've seen your practice do in particular is actually the appeal at the physician level. There's a lot of practices where they rely on the attorney's office to file things like independent medical review. So can you describe a little bit about what that internal appeals process is on your end?
When I told, what I mentioned earlier is they have a timeline deadline. It's basically 5 days. They can delay a little bit longer if they need additional information, but essentially you should get that first result from the insurance company about 10 business days. If they deny the medical treatment, you can appeal the utilization review decision. For that appeal to be effective, though, it requires your physician to look at the reason the doctor said no. And it's time consuming. You got to open up the document. Why did they say to no more physical therapy or surgery for the shoulder, whatever you're requesting? And you also have to have knowledge of the guidelines and say, well, your reason for denial was this, but that was an error on your part. The patient should get this treatment because they qualify for that. And then you have to put that in writing and submit that to the utilization review department in the format of an appeal, so that your specific rationale for that patient of why that denial was incorrect was wrong, someone takes a look at it. As you can imagine, it gets pretty time consuming if you're getting, we're getting half of all our requests denied. And it turns out the way the timelines work is that your physician will have a month essentially from when the utilization review physician denies the initial treatment to request independent medical review. From a practical basis, then, the same time your doctor is requesting the utilization review appeal, they also need to be submitting an application for independent medical review. And I'll just throw a little aside here too, is that when Dr. Jamasbi was talking about the good old days when we were first in practice, there was another feature of that, is that in the rare instances back when we were first in practice, when medical treatment was denied, injured worker has the right to go to court. And they could get in front of a judge and they could say, the judge would talk to the injured worker and they'd usually be there with their attorney and say, well, why you here? And they'd say, well, I've had 2 doctors recommend shoulder surgery, and the insurance company says no. And then the judge would look at the insurance company and says, why you're saying no? And it was hard for them to often have a good reason. And that right of appeal to going in front of a judge over your treatment issue was taken away in reforms done about almost 10 years ago now, I think it is. And so unfortunately, our one of our biggest helpers for ultimately getting treatment that our patients needed, which was their attorney, the attorneys now are really barred from helping out with that. So it's really even more dependent on your own physician and how aggressively they're appealing treatment, how specifically they're writing reports for the physicians at utilization review and an independent medical review. It's really critical because that's the only advocacy you're going to have to get medical treatment.
Mm-hmm. Changing gears a little bit, Donny, you're a physician assistant. Can you tell us a little bit about what your role is and what it is you do in workers' comp cases?
Yeah, that's a great question. I think a lot of patients have that question about what a physician assistant is. And a physician assistant is a licensed clinician that can practice medicine under the supervision of a doctor. They can treat patients, come up with a treatment plan, diagnose patients, prescribe medications, order tests, give injections, but all under the supervision of a doctor. They can go into any specialty, so you can be in surgery one day, you can be in cardiology a different day, you can be in pain management a different day. That's the great thing about the flexibility about being a physician assistant. The training is a little bit different. So for MDs, they go to med school. There's 4 years of med schools. The PA program is 2.5 years. So they're taking what you learn in 4 years, condensing it and putting it in an accelerated program in about 2.5 years in a physician assistant studies program. After med school, usually med students go on to specialize and go into residency. PAs don't do that. We don't specialize. We're trained to be medical generalists so that after we graduate, we can go into specialty and to pick it up pretty quickly.
And what is the difference between a nurse practitioner and a physician assistant?
Well, there's actually not a whole lot of difference between the two. Again, they're both advanced practitioners that can practice under the supervision of a doctor. But nurse practitioners follow more a nursing model. You actually have to have a bachelor's in nursing in order to go into the nursing practitioner program. And I think they also kind of specialize in a certain sense where there's a population focus that they have to pick, whether it's pediatrics or women's health or geriatrics. And so that kind of differentiates it a little bit. But, day to day in the office visit, the average patient's probably not going to see much of a difference and know the difference between seeing a PA versus a nurse practitioner. The only instance that I would say is that some nurse practitioners in about 30 states, they can practice independent of a supervising physician. And I think California just joined that actually sometime like January 2023 maybe. I think this is the first year that they might be able to do that. I could be wrong, but I think that's the case.
So in the realm of patient care, what is the role of the physician assistant or a nurse practitioner in conjunction with working with the doctor?
Well, so I think you have to look at it. There are some concerns. I have patients say, why am I seeing a physician assistant? Why am I not seeing the physician? And first I want to acknowledge those concerns, right? it's confusing sometimes when you see a physician, then you see a PA, then you see the physician, and you see a PA. But I think the way you have to look at it now is that medicine is approached in a more collaborative teamwork environment. And so having more eyes on the treatment plan, I think it can only be advantageous to the patient. And so our role is seeing the patients, especially here more in follow-up, okay, as the physician assistant, and being able to, again, we can follow the treatment plan, come up with a new treatment plan, look at a new MRI, figure out if they need an injection or if they need more physical therapy, or go into a functional restoration program. And so I think it's, for the average patient in the room, it's hard to differentiate between, what a physician does versus a PA. I think a lot of that happens more in the background. After the patient's visit, I'll go to Dr. Morley or Dr. Jamasbi and say, hey, here's the treatment plan. This is the direction we were going. Do you guys have any other insights, or, do you think we're heading in the right direction? And, they'll say, hey, maybe we can go into this direction. I think that epidural injection is a good idea, but maybe afterwards we can try a facet injection afterwards. And so it's just a team-oriented approach to the treatment plan and for the patient.
Changing gears a little bit, can you tell me what a nurse case manager is?
We've been interacting with nurse case managers for many years, from the time of my fellowship at Stanford. The nurse case manager is really designed for complex patients. Like, there are patients who have multi-organ system injuries. Their care is really complicated. They have multiple doctor's appointments. And the purpose of a nurse case manager is to come in and facilitate their medical care, explain to the patient what's going on, maybe help with authorization, and in general, help the doctor get the patient through the system. Unfortunately, that's not what happens all the time. Sometimes insurance companies hire nurse case managers to push the legal case along, and that can sometimes become problematic for the doctor, because they're basically telling the doctor, when is this case going to be over, and there might be some disagreement with that. But in general, if there is a nurse case manager that is helping with managing the patient's care, they can be very useful. And I have seen cases where, I needed authorization for multiple specialties, and we needed to get care that otherwise would have taken a long time. The nurse case manager was very, very helpful in terms of helping me treat the patient. But then there are other situations where it might become counterproductive, but you really don't know what the purpose of the nurse case manager is until you actually start interacting with them during the case.
I would just add one thing. I totally agree with Dr. Jamasbi that most of the time, actually, our experience has been positive. Nurse case managers are honestly trying to help the injured worker and get the care they need, but not always. And I would just tell any injured worker that if you're getting the feeling that there's this nurse case manager coming with your appointments and they're getting in the way of your relationship with the physician, just be honest about that to both the nurse case manager and the doctor. And you don't have to have that nurse case manager sitting in the room with you when you're seeing the physician or seeing a mid-level like Donny. If it's best for you, or you have to talk about something that's private and something you don't feel comfortable talking about in front of someone else, just ask them not to be in the room with you. You have a right to have a relationship with your doctor, and for it to be between the two of you, and not have that interfered with. And if you have a nurse case manager, it's great, and they're supporting you and they're helping you, fantastic. As we just talked about all the difficulties of the work comp system, the more help, the better. But if it's not that kind of relationship, just be honest with your doctor and say, I don't really want them in there. I need to just be one-on-one with us. And every physician I know would respect that.
Would you say more often than not that patients are comfortable having the nurse case manager with them at the appointment, or no?
My experience is that most of the time the patients don't want them in there. And I don't really see any use of a nurse case manager being in the room with the patient. It just crowds things up, and I think that what the nurse case manager needs to do is to take the doctor's recommendations and facilitate those decisions, rather than being in there as an independent clinician observer type of thing, because that can sometimes cause a conflict with the findings. So my recommendation is always for nurse case manager to stay outside the room and then come in afterwards when I'm explaining to the patient what's going on. And I think it's important for her to be there because I want that nurse case manager to hear what I'm saying independently and hopefully help me facilitate the treatment.
I would agree with that in most cases, except for cases where we have patients that have brain injuries, right? And they have memory and concentration issues. And I had a couple patients where they have difficulty remembering when their appointments are and difficulty remembering when they do see the doctor what actually happened. And so giving that history to us, it makes it more difficult. So the nurse case manager can go with them into the visits with the surgeons or with the other doctors and be able to tell and say, hey, you know, this is what the patient saw this surgeon on this date, and this is what they talked about. And it helps with the history. So in those cases, I think being in the office with us, I think would be important for the patient, especially if they don't have a family member helping out with some of that history.
So on my side of things, I've seen nurse case managers kind of piggyback on what you had to say, being there more so to facilitate care. If we had clients with catastrophic injuries who've lived in remote places who need help with transportation or finding appropriate specialists. And we've also heard from clients too on the other side of things that they were there just to ask about my work status and ask why I wasn't permanent and stationary and stuff. So from your perspective, I assume you've kind of seen both then?
Yes, I have. Absolutely. I think the nurse case managers are hired by the insurance company. The theoretical purpose is to facilitate care. But a lot of times what happens is that the nurse case managers get involved in the management of the disability part of the claim. And there's motivation to move the case along to a permanent and stationary status so that the claim can be closed. I personally think they should have more of a clinical role, but they do take that role sometimes, which can sometimes be disruptive in the care of the patient.
I know as well, Bilal, like this, it doesn't happen in our practice, but I think that there are some physicians, especially if a physician's new to workers' comp or doesn't treat a lot of injured workers, and they maybe don't know the system that well, they can get a little bit bullied by some nurse case managers, and I think the patient feels that like the nurse case manager is kind of really driving the cart, so to speak, and patients don't like that feeling. Someone wants to feel like it's their doctor that's making the decision, that's running the show, or their physician's assistant if they're seeing them. And I think sometimes there are some physicians that are a little susceptible to getting bullied a little bit by the nurse case manager.
Yeah, I do want to emphasize that for patients, they have the sole right of refusing a nurse case manager to come in the room with them. So I don't think they should feel forced that somebody be with them. And, they have a confidential doctor-patient relationship, and if they don't want anybody in the room except the doctor and the patient, they have their absolute right to do that.
So we talked a little bit about, I guess, some of the roadblocks. Sometimes it can be nurse case managers. Sometimes it can be utilization review. Are there any other particular roadblocks you feel like you frequently run into when trying to give patients the care they need?
I think it's just, a lot of what I see is kind of life circumstance. So, the people that I see are working people. And we treat all people in all kinds of walks of life, all kinds of occupations. But, people who suffer the most work-related injuries tend to have the most physically demanding jobs. And a lot of times there's not a lot of period of time during that 2-year TTD window to get well and get back to work. And a lot of the people I treat, really, some of the limitations of them getting treatment is that they can't afford to be not working anymore. They have, a spouse or children at home to support, sometimes an only single working parent, and really a lot of financial barriers to being able to maybe engage in the time to recover from an injury and engage in treatment. That would be ideal, but they have real world financial considerations that are very, very tough for them to manage.
One of the biggest problems I see is access to specialty care. If you look at the medical provider network in workers' comp, there is orthopedics, there is physiatrists, there's pain management doctors. But then if patient needs another specialty, it's very difficult to find a psychiatrist, almost impossible. They have doctors on the list for other specialties such as plastic, ENT, urology, but typically those doctors don't accept workers' comp. And so getting specialty care outside of the musculoskeletal system, I would say, is nearly impossible to coordinate. Even if you can get it authorized, the patients usually end up not seeing the doctor because the doctor doesn't really see workers' comp patients. So that's a huge problem in workers' comp. And, we've had people with eye injuries, people with liver injuries, internal medicine problems, dermatology. People have disfiguring problems, and they need dentists, they need plastic surgeons. Those are very, very difficult to access. And the other issue is that the patients encounter is when they have multi-system trauma. They come out of a trauma center, they're 2 months out from San Francisco General Hospital or another trauma center, and they come out in wheelchairs with braces. They need to see occupational therapists, speech therapists. So there's this complex system of care that was given to them in the trauma center or in the hospital, and they come out, and every single one of those has to go through utilization review and IMR, and it becomes literally impossible to provide care for those patients.
Donny, do you have anything to add?
Yeah, I mean, building on that, I think a big roadblock sometimes is the employer, right? These injured workers are injured. We have them on work restrictions. We're trying to get them so that they can get the treatment that they need without aggravating their pain at work. And we get sometimes patients that say, hey, my employer's not honoring my work restrictions. I'm aggravating my pain at work. And that's a roadblock to our treatment, trying to get them better, get them back to work. But sometimes employers, it seems like they're not working with their injured workers to be able to get the treatment that they need.
Well, before we wrap up, I just wanted to get one last final word from each of you. There's a lot of people going through workers' comp for the first time, and they may be scared. They may not necessarily know what to anticipate or things coming down the pipe. So, I'd like to hear from you guys regarding some of your sage wisdom. What would you say to someone as a word of advice going through the system?
Try to find the right doctor right at the beginning. A lot of times patients end up at clinics that are basically spinning their wheels. They waste 3-4 months of time. They don't really get proper treatment. I think it's important, if you're injured and you want to get better, make sure you access the proper medical provider right away. After 30 days, you have the right to choose your own doctor, so you can exercise that and be your own advocate. And the third thing is understand the system. Understand how long you're going to get paid for your temporary disability. Understand what the limitations are, so that you can get the proper treatment on a timely basis and hopefully get better and move on with your life.
Donny, how about you?
For me, it would be to get a good workers' comp attorney. Maybe Pacific Workers can help with that, right? No, in seriousness, you have medical advocates here at Pain and Rehab advocating for the patient medically. But, with workers' comp, there's the medical side, but there's also the legal side as well. And having a good workers' comp attorney that can help you navigate those legal waters, I think, is important, because it can be really confusing on that side too. And we have patients asking us legal questions, and we have to defer and say, hey, we're not attorneys here. We can answer maybe basic questions, but really those questions need to be asked with your attorney.
Dr. Morley?
I think I'd reiterate what Donny said about patience. Just remember that your number one asset is your health. You can't be useful to your family, your friends, your community unless you're healthy yourself. And there's going to be a lot of things that probably do happen during workers' compensation claim that are frustrating. Try not to take it personally. I don't mean to be so pessimistic, but I often tell my patients, don't take this personally. They treat everybody equally as badly. And I think that's true. And it's hard not to. And stay positive, get better, because that's really what matters. Hopefully you have a good attorney helping you, have a good doctor helping you, and you're going to make your way through the system. But what really is more important to you at the end of the thing is that you being as healthy as you can be. That's the most important thing.
You heard it, guys. Doctors, Donny, thank you for joining us today. Make sure, again, you guys hit that like and subscribe button, and we'll see you on the next episode.